There's no real specific or sensitive test that can be used to diagnose this with absolute certainty. ESR and CRP are nowhere near specific for this disease, and temporal artery biopsies can come back negative even though the patient is thought to clinically have giant cell arteritis. So in lieu of these poor diagnostic modalities, it's kind of, the literature has suggested that clinicians typically rely on their clinical judgment for the treatment of giant cell arteritis. And so that begs the question, do we need to put patients through unnecessary invasive procedures like a TAB in order to diagnose this? For a little background, the American College of Rheumatology actually puts out diagnostic criteria. And if you kind of glance at that list, it's pretty non-specific. It's patients that are over 50 years of age. They have a new onset of a localized headache. They have an ESR that's elevated, and then they could have temporal artery tenderness to palpation or decreased pulsations, and then the biopsy as well. And you only need to fulfill 3 of these 5 criteria in order to get a diagnosis of GCA. So you could be a 50-year-old with a slight headache and an elevated ESR and technically carry a diagnosis of GCA. So I looked at some of the literature, and back in the UK in 2017, there was a retrospective chart review that evaluated the clinical utility of TABs on the decision to continue or taper steroid treatment. 129 TABs were performed between 2012 and 2014. 17 of those biopsies were confirmed positive, and 10 biopsies had insufficient sample to confirm. And all of those cases went on to receive a full course of prednisone. 102 patients had negative temporal artery biopsies, of which 89 of those were continued on prednisone on clinical means alone. 84 of the 89 that were continued despite a negative temporal artery biopsy had an ACR score that was greater than 3, fulfilling the clinical criteria for the diagnosis of GCA. These are some of the tables from the paper. It just looks at demographics and other things. The main thing that I want to draw your attention to is what we just talked about, those TAB negative patients. 89 or 87% of them continued on the full course of prednisone despite having a negative temporal artery biopsy, and only 8 of them, or 8%, had a tapered course. So this just kind of highlights kind of the insignificant role that temporal artery biopsy plays in the management of GCA, at least in that institution. Another study I looked at the value of ESR and CRP in diagnosing GCA. So this took a look at 764 patients with documented ESR and CRP values 6 weeks prior to undergoing their temporal artery biopsy or having treatment with steroids. And 587 of them had negative biopsies, 177 had positive biopsies. Of the people who had positive biopsies, 84% had an elevated ESR, while 86% had an elevated CRP, and 80% of positive temporal artery biopsy patients had both elevated ESR and CRP. So those look like good values, but when you look at the ACR criteria, if you were going to diagnose just clinically alone, 93% of them would fulfill the criteria. And then looking at after they received a temporal artery biopsy, those patients that had a negative temporal artery biopsy, try to circle right here. I want to draw your attention to 70% had an elevated ESR CRP despite having a negative temporal artery biopsy, and close to 60% had elevated ESR and CRP. So this just kind of gets at this diagnostic dilemma of how do we go about diagnosing this? Is there a good way to better assess this? And it led to my investigation of how we approach it at KU. With this literature review and then my own kind of limited clinical experience, I made the 2 hypotheses. And that's that temporal artery biopsies are less influential in clinical judgment on the decision to treat for giant cell arteritis. And then I wanted to try to assess our objective means of GCA because I felt that they were poor predictors of which patients would go on to receive treatment. And so I set out 3 goals to evaluate these hypotheses. The first one was to determine the percentage of patients that would go on to receive treatment despite having a negative or indeterminate biopsy. And then goals 1, 2, and 3 kind of go hand in hand, but it's to assess our objective means of GCA and then evaluate ESR and CRP values as predictors of disease. So my design was a retrospective chart review. I looked at all tabs that were done over a 10-year span, which was a lot of cases and a lot of charts to review. I looked at biopsy results, treatment with corticosteroids, and then evaluated their ESR and CRP values prior to biopsy or steroid treatments. The age range of patients that were biopsied fell between 55 and 94. This is a lot of words on this this page, but 250 total temporary biopsies were performed. 201 were read as negative or indeterminate, with 185 being negative and 16 indeterminate, and 49 were presented as or were reported as positive for arteritis. Of the positive cases, all of them went on to receive a full course of prednisone treatment. Of the indeterminate biopsies, 50% of the 16 patients went on to receive a full course of treatment, with the other 50% getting a short tapered course. And then the big section I want to look at was the negative temporary biopsy patients, and see who got treatment and how that affected our clinical decision making. And you can see that about 3/4 of that negative sample went on to get a tapered course of prednisone. And that's 140 patients that we saved from long-term steroid use. 11% didn't have sufficient clinical grounds to even begin steroids in the first place, and then 14% we clinically diagnosed despite a negative temporal artery biopsy, and they got a full course of treatment. Looking at ESR and CRP values, in temporal artery biopsy positive patients, about 67% had an elevated ESR and 53% had an elevated CRP. And TAB negative patients had 63% elevated ESR and 42% elevated CRP. So you can see that, again, this is just a very non-specific test. It shows that there's inflammation in the body, and it's somewhere, and it doesn't necessarily indicate whether they have GCA or not. But when I looked at the magnitude of elevation, there actually was some statistical significance. So patients that had a negative or inconclusive biopsy had an average ESR value of 44, whereas if they had a positive TAB, they had an average ESR of 57, and that was statistically significant between the two groups. And then the CRP also had a larger magnitude if you had a positive result, 3 versus 7. So kind of my interpretation of the data, it would indicate that TABs actually do play a significant role and have a significant impact in the decision to treat for GCA. 100% of our patients that had positive biopsies were treated GCA, I think appropriately. And then of those that had a negative biopsy, only 13% or 13 to 14% had to undergo a full course of treatment with steroids, which we know is not a benign therapy. The vast majority, 3/4 of them, were actually able to be tapered off quickly, and it saved them long-term immunosuppressants or corticosteroids. And then ESR and CRP elevation alone didn't seem to be a useful indicator of the presence of disease, although if we could somehow stratify the magnitude of elevation, we may be able to correlate that to some kind of presence of disease. One thing that wasn't looked at in this retrospective chart review was platelet count, and that is another factor that we often assess when we're looking at patients with giant cell arteritis, so that's something that can be looked at in future studies. And then areas of literature that were critical of temporal artery biopsies talked about non-invasive means of assessing for GCA, like ultrasounds and Doppler ultrasound, or MRIs and Doppler ultrasounds. And while these are sparingly used, they have shown some promise in getting a diagnosis. There's my references.
Have we ever had any cases here where we've used the MRI or ultrasound and then not done a biopsy because of that?
So I didn't I saw instances where we did not do a temporal artery biopsy, and I didn't include those in the study because I just looked at patients that underwent TAB. But especially rheumatology, I saw a couple of times where they would just get the MRI or they get the ultrasound and then they would go on to treat clinically.
I've done that before, like in patients who have other rheumatological illnesses, so their Sedgwick and CRP are elevated, but you don't really know what to make of it.
Right.
And if that's like totally normal, then you don't go on to do the biopsy. But if it were more borderline or abnormal, then you could do a biopsy.
Many of the tapered patients have like visual compromise because they were tapered.
That's a good question. I didn't delve that deep in each chart. There's too many charts to look through.
Okay, thank you.